program is a book discussion on Dr. Azra Raza's latest book, The First Cell and the Human Costs of Pursuing Cancer to the Last. In her book, Dr. Raza explores cancer from every angle: medical, scientific, cultural, and personal, as she argues that we are overdue for a change in the paradigm for treating cancer. We're honored to have Dr. Raza with us for a discussion on this very important topic which has impacted many of us, either directly or indirectly. Dr. Azra Raza is Professor of Medicine and the Director of the MDS Center at Columbia University. Previously, she was the Chief of Hematology-Oncology at the University of Massachusetts. She's considered an international authority on pre-leukemia and acute leukemia, and is the recipient of the Hope Award in Cancer Research shared with the Nobel laureate Dr. Elizabeth Blackburn. Dr. Raza has also met with former Vice President Joe Biden to discuss the Cancer Moonshot Initiative in 2015. Our moderator for this evening is Dr. Martin Raber, who over a 37-year career at the MD Anderson Cancer Center has served as a clinician, clinical investigator, and teacher. He's also served in a number of senior administrative positions at the Cancer Center. Major battles with lymphoma caused him to interrupt his career a number of times and contributed to his eventual retirement. Dr. Raza's book will be available for purchase after the program. Please join me in welcoming Dr. Raza and Dr. Raber. Thank you.
Well, I appreciate that everyone's here. It starts with Dr. Raza. When I was asked if I would consider moderating this discussion, I replied, well, first I need to read the book, and then I'll tell you. And I read the book over the Christmas holiday, and it's an extremely powerful book. It has many messages. It's equally accessible to the layman who knows nothing about cancer, except they may know someone who's been treated for the disease, as it is to the cancer physician or cancer researcher. It works at many levels: scientific, and personal. And it is in many ways a very emotional story. It blends the science, the past, the future, and the personal stories of many people. For me, it was a pretty quick read, which is to say it's a compelling book. I usually read mysteries, and so I like a page turner. This is a page turner of a different kind, and I would encourage you to pick it up and read it. I think it's enlightening. Now, having said that, I don't necessarily agree with all the points that she makes, but I think the points are valid and worth discussing. And today we're going to discuss a little bit of science and a good bit of medicine at the personal level, that is to say, the patient level, and talk a bit about the past and the future. It's a powerful book, and to start, I'm just going to ask Dr. Raza to read us a passage from it.
Thank you, Marty. Thank you to Selina Jaffrey. Thank you to Asia Society for organizing this wonderful program. And thank you to all of you for taking time out of your busy schedule to come and attend this. Part of the reason that all of us are here is because cancer is not anymore something that happens to someone else. All of us in one way or another have been touched by it, whether it's directly or 1 or 2 degrees of separation at most. There's in fact, somebody quoted to me what Dr. Uzma Iqbal has said, that if you live long enough, you're going to get cancer. So it is definitely a disease of the aging, and as the population is aging, more and more people are getting cancer. So what I'm going to start with is read you a passage which is not at all doom and gloom. It's a very futuristic and a very optimistic vision of the future. Because I really think that this is where we are going, and I'm very excited that I'm alive in this day and age to be able to witness this firsthand. Ian?
Yes.
Imagine a machine that automatically images your entire body while you're in your morning shower. Or a smart bra that has 200 tiny biosensors built in to monitor micro alterations in temperature and texture worn for only an hour a week. It generates sufficient data on an accompanying app to show distortions created by the very first few cancer cells. Or taking a pill whose contents are absorbed preferentially by cancer cells and extracted in the urine and detected in a fit lube. How about yelling at a cancer using ultrasound, compelling it to reveal its presence and its lethal potential as the tumor is forced to shed more markers into the blood when hit by waves at the right frequency, or exhale deeply into a device that accurately recognizes the earliest footprints of cancer, or simply prick your finger periodically to provide a drop of blood to a magneto-nano-sensing device that identifies surrogate markers of malignancy instantly. The above are not scenes from the Fantastic Voyage. These are real-life technologies in various stages of development today, heralding the dawn of a new era in cancer research. Sam Gambier at the Canary Center at Stanford University is at the forefront of this revolution in early detection of cancer from blood, urine, stool, saliva, breath, and tears, using a host of genetic, sonic, and imaging methods. The emergence of these groundbreaking technologies is a direct result of collaboration between experts coming from many disciplines: geneticists, biomedical engineers, radiologists, oncologists, molecular biologists, nanotechnologists, AI experts, computer scientists, and bioinformatics wizards. Even in sports, teamwork and cooperation win the day. Why not in cancer? Here's one scenario for the future. Everyone from birth to death is regularly screened for the first appearance of cancer cells in the body. Once detected, protein markers would be identified, providing a zip code for the cancer cells. A tube of blood from the individual would be obtained. T cells would be isolated, activated, armed with the address for the cancer based upon the unique protein barcode that the RNA signature is expressed. These CAR-Ts can be injected back into the individual to seek out and kill every cell with the right address. None of the basic toxic effects seen with the present CAR-T therapies would be an issue because the tumor mass would be minuscule compared to what we target today. Eventually, we should not even have to draw blood for screening. Rather, every infant would be fitted with an implantable tiny device at birth that would constantly monitor for such a mishap. Send signals in a timely manner so that confirmation, validation, and treatment could swiftly follow. The ideal is to find every cancer at the precancerous stage through perturbations in disease-prone networks detected via dynamic monitoring by implanted devices. Of course, this is the dream scenario and far from current practice. There are 1,000 slips between cup and lip. But we will never get there if we don't start. Besides, I have great faith in the ability of humans to step up and innovate rapidly as long as we set a goal and we financially incentivize this goal. The goal now should be spelled out in no uncertain terms. We are to stop developing minimally effective therapies and go for nothing less than a humane cure that will be applicable globally. The best cure will be prevention. To detect the first cancer cells footprints, a map of early biologic markers of cancer have to be constructed. This is what our resources should be targeting. Thankfully, the race has already begun. We all benefiting from cooperation at the deepest level. Heed the advice of an anonymous sage who said, if you want to be incrementally better, then you can compete. But if you want to be exponentially better, cooperate. And this is what I wanted to read, but before I turn over to the skeptics, I just want to show
I think you meant me.
the M. No, I see many in the audience too. Something called the M chip. This M chip is developed by biomedical engineers at Columbia University that I'm working with, Dr. Sam Sia. It is now FDA approved already. This is not a pie in the sky. So here is where this is not some Elizabeth Holmes Theranos candy. This is not a Ponzi scheme of cancer. This is real. This is what I wanted to show you. You put a drop of blood here, and it through these microfluidic channels, it goes and it can interact with the antibodies that we put there. So this detects PSA, which is the prostate-specific antigen that men need to monitor for the presence of prostate cancer. And this can be inserted and read through a device that comes with the chip, these disposable chips. Men can simply have the device and this chip at home now. It's FDA approved. And measure their PSA level twice a day if they want, once a month if they want. This is the kind of thing we are talking about. So as I said, it's not all just talk. These are all in various stages of development, and the same with this implantable chip that we are working on with the biomedical engineers. Right now the chip is on the skin, but we want to do it an implantable under the skin device eventually, which one of the very smart PhD students is working with us to do that. Okay, thank you.
It's a fascinating book, I already said that. It talks about the world today and the world tomorrow in science, but it also talks about the world today in terms of the humanity, the fight that patients with cancer face, patients and their families, and their physicians. And what I'd like to do is kind of work through those concepts and tease them out a little bit. And we'll start with the world today. 1971, Richard Nixon signed the National Cancer Act. I am personally extremely thankful. It paid for my training in oncology. It paid for the major cancer centers that populate the country at the moment. And it resulted in a cancer program that spends about $6 billion a year, mostly on cancer research. But what most people ask about is what they called it in the newspaper, which is the war on cancer. Now, every year or 2 years or 5 years, we read an article that says the war on cancer was either won or lost. Last month, we were losing, but this month we're winning. It's really hard to follow. War on cancer. Attempt to eradicate cancer. When Andy von Eschenbach took the FDA position, he redeclared war on cancer and said it was going to be eliminated by 2015. We had the ability. It's in our hand. How are we doing?
We are losing.
We're losing, okay?
Tell all the truth, but tell it slant. Success in circuit lies.
Success in
circuit lies.
Circuit lies.
Too bright for our infirm delight, the truth's superb surprise. Like lightning to the children, eased with explanations kind, The truth must dazzle gradually, or every man be blind. This is the admonition of Emily Dickinson. Tell all the truth, but tell it not. No one is willing to face up to the fact that 50 years later, and as you said, a minimum of $6 billion now a year, that's just government funding of cancer research, but there's a lot more from philanthropic and other sources.
Philanthropy foundations,
Foundations, philanthropy.
another couple of billion a year, yeah.
Another couple of billion. For breast cancer research alone, they raise $6 billion a year. So all this money has gone to what? To try and develop better therapies of cancer. Where are those therapies? We are still treating most cancers with chemotherapy, radiation therapy, and surgery. So the promise of all those new therapies that we were going to identify exactly what's wrong in a cancer cell and target it with magic bullets, they have not come about.
Well, there are some great successes.
With very few exceptions. Yes, there are very few exceptions. So, for example, let's say immune therapies today.
Well, no, let's just talk about first about, before we get to the immune therapies, targeted therapies, starting with antibodies directed at cancer and taking them through. CML dramatically improved. Breast cancer with Herceptin, lymphoma with Rituxan. These are drugs that made really significant differences in patient populations.
I absolutely agree. There's no argument with that, yes. But is that enough?
It's never enough.
Okay. Yes. So the majority of patients, so let's start with CML, which has the best therapy so far. Chronic myeloid leukemia. Note the first word, chronic. So that's why it's curable. But chronic myeloid leukemia is a disease which was thoroughly studied. Turned out that there is one genetic change that causes this disease. This genetic change was targetable with one magic bullet, the drug imatinib. This drug cures the disease. Today when I started my fellowship and Marty started his fellowship, this was a dreaded disease when these people turned towards acute leukemia. This was a 100% universally fatal disease. But yet today we cure it in chronic stages.
I guess we're having a discussion about the glass being half full or half empty. Or in cancer treatment, I would say it's a third full or 2/3 empty, depending on how you look at it. I see patients all the time whose lives have been extended by current cancer therapy, some dramatically. If we look at immune therapy and immune modulation, the checkpoint inhibitors, it's dramatic, and we still don't even grasp the full use of those drugs. But I see all over patients living longer, some cured, many not, than before the therapies that we have today were available. When I look at the armamentarium in 2021 versus the armamentarium when I began as an oncologist in 1978, it's dramatically different. And I guess when I listen to you say we need to stop developing therapies the way we are and start working on this, I say, wait a minute. We're developing therapies that are having real effects, but you are correct. In many cases, we are not curing the diseases.
So go ahead, how do we cure? You answer it.
Okay, so first of all, if we look honestly, and we're here to look honestly, if we look honestly at the successes of cancer in terms of decreased mortality from cancer, we all have to admit that the majority of those decreases come from early detection and screening. And the minority come from great chemotherapies or biologic therapies that have been developed. So that's an observation that you make in the book that is entirely correct. It's also true that many of the historic techniques that we use to develop anti-cancer therapy have a pretty poor track record at doing that. And if we look at what's exciting today in anti-cancer therapy, it's the immune modulation of the so-called checkpoint inhibitors. That was a Nobel Prize in 2018. It's the molecular therapies, the targeted molecular therapies, which we can have a separate discussion about. It's less the development of classical chemotherapies. So it's really, though I don't agree with the idea that we should stop developing these agents, because I see the benefit of them all the time, I don't disagree with the fact that our progress has been slow and in some areas pitifully slow.
Okay. Allow me to say this. Nowhere in the book have I said that we should stop doing this therapy. Nowhere. So I have to correct Marty in this. All I'm saying is that shouldn't be the only strategy we keep pursuing.
That's not quite the passage you read.
Not the passage I read, but I didn't read the whole book. The passage I read was simply about what can happen.
We spend a lot of money on cancer development. If the question is, are we doing it the right way and we need to continue, I think we all of us in cancer work, research work, would say we're making progress, but we need new ideas and new ways of thinking about it. But I think we have to look and ask the question of how do we get those new ideas into the pipeline? How do we get them started, or they're already started, further along? So how do we pay for cancer care? The government pays for cancer research rather, $6 billion a year. The pharmaceutical industry pays for cancer care, but they're only interested in things that are going to be profitable to them. Philanthropy and foundations pay a significant amount towards cancer research rather. How do you propose turning those groups towards this kind of program?
Will you let me answer or no? The last one you didn't.
You gotta come right out with the answer, okay?
I think it's very simple. Right now, the new treatments that we bring to the bedside, 95% of them fail entirely. The 5% that succeed, in my opinion, most of them should have failed. None of them are almost none of them are curative. The kind of advances that Marty mentioned, antibodies, Rituxan, the kind of Herceptin, these are at least 20 years old. At least 20 years old. The checkpoint inhibitors Marty is talking about, I mean, I have covered that whole subject in the book in no uncertain terms. These are palliative treatments that extending the life for an average of 5 months for 20 to 30% patients. At the cost of what? Billions of dollars going into pharmaceutical industry. So this is exactly the kind of point of view I am challenging and saying enough already. All these rosy pictures of wonderful advances is simply not true. Look at the data. I can't make up. The data are so bad that I can't make it up. The things you're talking about, of course, yes. I'm not saying there's no advance. And I'm not saying that we should stop the current pursuit of cancer research either. All I'm saying is, yes, we have current patients, Marty. We need to worry about them. They have cancer. We have to treat them.
We
need to continue to follow these patients, follow all the therapies that we think look promising, do all the clinical trials, do all the research. I'm saying some more resources should be diverted. You asked me, how do I suggest that more money should go into this new goal? I think it's very easy, Marty. If we set the new goal, imagine that here are all these industries which are investing in an enterprise that has a 95% failure rate. And they are willing to put in billions of dollars in that investment, in that venture. How about setting a new goal of finding earliest detection of cancer and incentivizing that goal? Everyone will turn around overnight. And you know the example I like to give? Imagine that in this day and age, we are doing colonoscopies to diagnose and screen for early detection of colon cancer. Once a year, somebody puts in a tube in your gut and looks around for cancer. This is Paleolithic compared to the technology that we have. This is Stone Age technology. Looking by eye for a tumor. Where is all the AI? Where is all the imaging? Where is all the scanning? Why aren't we using the latest things to do that? And technology takes over so quickly. You know, I'm from Pakistan, Marty. So I go back, not as frequently as I'd like to, but I do go back. And in the last 40 years, the change that has happened in an underdeveloped country like Pakistan. I'll give you one example. We get stuck in a traffic jam, and if the traffic jam is bad and you're waiting there for many minutes, homeless people, beggars, they'll come and start knocking at the window. Same thing is happening in New York also, by the way, but Karachi more so. They come and start knocking at your door. So I was stuck in a traffic jam in Karachi, and this guy starts knocking on the door. Before I could roll down my window, his cell phone rang. And he took out the cell phone, answered it, and looked very concerned. And he puts it down. I said, "Is that everything okay? What happened?" He goes, "No, that was my wife saying there are longer traffic jams near the university." She's saying I should take the Uber and get there. This is how technology can take over entirely. I'm saying, who would have imagined that 10 years ago you would go to Karachi and I would have a cell phone, or 20, no one. But this is how things can happen and turn around. So I'm very optimistic, I'm very excited. This is why I showed everybody in the opening remarks, the M-chip, that it's not a pie in the sky.
I think that early, what you're talking about is earliest detection. And it's hard not to be for early detection.
Yeah.
I see a lot of, you call it many slips between the cup and the lip. I see many obstacles to getting there, but I don't consider that a reason not to do it.
Yeah, of course.
What you have to create is a consensus at a high level of investigators that this is a good plan. Because if you look at how cancer is funded, we talked about you get it from foundations, you get it from the National Institute of Health. Everywhere you get it, your funds are quote unquote peer reviewed. Your ideas are presented to a group of
I want to stop you there because it's not going to be through that way. What's happened is Toshiba announced just 2 weeks ago, Toshiba in Japan announced that they have developed a test with 1 drop of blood. You can detect early markers of 13 common cancers at home for the price of $180. You can do this at home. They announced this. This is what's going to turn things around. Not that I'm going to go begging some billionaires or begging the NIH to change their perspective and please start funding grants. No. This is the good part of capitalism. That, you know, when you have competition, they are going to really invest, attack, and do this. If the Japanese have done it, why can't we do it? What is Silicon Valley doing? Why aren't they rushing into the competition? This is what will turn.
There is no question that many of the advances in medicine today are driven by venture capitalists who invest in small companies or larger companies that have a great idea. And they are, and the amount they can invest is logarithmically more than a small foundation, or that you're going to get on a grant, an Orwell grant from the National Institute
the old
There.
boys network giving each other grants, they are never going to get cancer cured, believe me. We will get it cured by having imaginative young people competing with each other, using technology, using devices, using scanning measures, using biomarkers instead of those ancient technologies developed 50 years ago, like mammograms. Why are we using mammograms? There is a smart bra undergoing clinical trial, as I just showed you. Those are the things that will simply, you see, it's like if we kept trying to improve the typewriter, we would never have the word processor. My cousin Azra Raza is sitting here. He saw my father use the typewriter all the time. That was his biggest love in his life was, I think, the typewriter, because he got so much done with it. But who thinks of a typewriter today? Because the whole paradigm shifts instantly when you have a better thing. And that's the one lesson, Marty, I learned from Thomas Kuhn's Structure of Scientific Revolution. That is a book I read every year or two. Because he made this very simple point. You want the paradigm to shift? Show a better way. That's it. Talk is cheap. Also, I want to give one other example before I turn back the questions to Marty. The human genome was sequenced more than 20 years ago now. It took 15 years and several $1 billion to sequence the first human genome. 15 years. Today it is done in a few weeks for the price of a few $100s. Within 20 years, we came down from $3 billion to few $100s. From 15 years to not even 4 weeks. When I put enough pressure on my sequencing people, the core facility will say, okay, we are making an exception for you, Dr. Raza, we give you the sequence. Immediately, a targeted sequencing, unbelievably fast. So this is why I'm so excited about the future. This is why I'm very optimistic about the future of cancer.
I mentioned that she was passionate about it. Okay. I told you there were 3 parts of the book. Where are we and why are we stuck here? Where are we going and what will it look like? That's 2. The third is much more personal for Dr. Raza, perhaps more emotional for her and for all of us who treat cancer patients. And it's that tagline under the first cell that tells you there's something else going on here. And that is the question of the human cost of cancer to the cancer patient. And the human cost of cancer to the people who are caring for the patient, the doctors, nurses, and techs who are dealing with the patient over those years. Now, you chose a really hard specialty. I'm not a hematologist, I'm a medical oncologist, but when people tell me they have myelodysplastic syndrome or myelodysplasia, I take that as a bad sign. I consider it a difficult disease. I consider it a disease in which the majority of patients are going to succumb to their illness. You see those patients every week. You deal with those patients, and you, I can tell from the book, are more, I suspect, much more involved emotionally with many of those patients than other physicians. 2 things. The first one is talk to us for a few minutes about what that cost is to those patients. And then we'll talk a little bit about how you as a physician or I as a physician, understanding the realities of the disease, deal with them and deal with that ourselves.
So that's a very, as you said, a very emotional aspect of this field for me. I wrote this book, The First Cell, because I wanted to look at everything we do in prism of human suffering and anguish. And not just human suffering that is visited upon the patient, but also the families. So I think a very unique part of this book is that years after the individuals died, whose stories I tell, I go back to the families and I ask them, with the benefit of these years that have now gone by, you've had time to digest, time to accept. If you were to cast a backward glance now, what decisions would you change? What things you should have or would have done differently? And they have written their answers. And that makes for the kind of page turner that you're talking about, because this is real life patients, this is real life stories. My daughter, whose best friend Andrew, this beautiful gay young man, had been Scheherazad's friend since she's 15 years old. When they are both 22, he feels some weakness in his arm, goes to the emergency room, and he's diagnosed with an inoperable 9 centimeter long brain tumor. Now this is a 22-year-old beautiful young man who within hours is quadriplegic. Now from that moment that he was operated on, every oncologist who took care of this young man knew that there is 0.00% chance for him to survive longer, no matter what we give him. He opens his eyes, the first thing he says is, "Mom, don't worry, just call Azra. She's on the cutting edge of cancer, she'll find a cure for it." How ashamed I felt. How have we failed the Andrews of this world? This 22-year-old boy is lying there, full of his confidence about my ability to treat him, and what do I have to offer him? Nothing. No, not nothing. In the next 16 months, what do we do to him? Surgery after surgery, chemotherapy after chemotherapy, radiation therapy after radiation therapy, more immune therapy, more chemotherapy, more radiation therapy, until this poor boy dies in little installments, and his mother and his father, his grandmother, his sister, they all have to stand there and watch him go through this. These are the kinds of stories that we see on a daily basis. So I can't go around thumping myself on the chest and congratulating myself that we have made great progress in cancer. I just can't do it because we are faced with this every day. And even if there is one Andrew dying, I ask the question, why aren't we doing better, and what can we do to do better? If we keep telling ourselves that we should be complacent, we are on the right track, we are making great progress, then we really will continue like this for another 50 years, doing the same old, same old. Going forward, what is the strategy? To me, what strategy has worked until now? Early detection, prevention, screening measures. Well, we can't screen all 300 million people, but we can start screening people who are at high risk of getting some type of cancer. Women with a BRCA1 or 2 mutation who are at high risk of getting breast or ovarian cancer. But the same way, maybe there are things which make people susceptible to pancreatic cancer, to brain tumors. So we need to do all this work. There is so much to be done. So much will come out of this kind of research. Once again, I want to end by saying that it's the human costs of cancer which really shake us up. I have been treating cancer myself for 20 years when my own husband got the very disease he had dedicated his life to cure. And still, until I shared a bed with a cancer patient, I had no idea how dreadfully painful a disease it is. What is the anguish of a patient? Once Harvey's adult children from his previous marriage cornered me and he said, Dad never talks to us about his illness. Every now and then we get a call from you saying he's in the ICU and we have to drop everything and come. Why don't you tell him to talk to us? So I went to Harvey, and that night I said, Harvey, your children are right, they're adults, and he adored them. I said, why don't you talk to them? He said, so much of talking to others is about asking for help.
Yeah,
He said, no one can help me, so why talk to them? I'll only end up worrying them. So I still pushed him. I said, but they'll feel better if you share it with them. And this is the answer he gave me. He said, I don't have the energy left to help other people deal with my illness. He said, you talk to them, I can't. This is the pain. This is the anguish I'm talking about. This is something we have to realize what patients are going through, what families are going through. And why aren't we thinking of doing better things?
talking to your children when you're ill with cancer is possibly impossible. Let me ask you, I've been asking all these questions for you guys. I'm going to ask you a question for me, maybe a little off the topic. When you see this young patient with a brain tumor, when you see this patient with acute leukemia, this middle-aged elderly man, and you understand that 0.0% chance of getting better, and you understand for that brain tumor patient what the next 3 or 4 or 6 or 12 months are going to be. What do you tell that patient who says, Azra, what should I do? What should I do? And how do you deal with the patient whose response to hearing that their cancer is going to be fatal, that patient who is totally unrealistic and is out circling the world trying crazy ideas in Germany and Africa, wherever, and wants your advice, trusts your advice, what do you tell them? The patient wants to be cured. The patient thinks you can cure him, but you know it's 0.00.
Yes. Whenever I see a new patient, I'm going to quote Dickinson again. I felt a cleavage in my mind, as if my brain was split. I tried to match it seam by seam, but could not make them fit. The thought behind I strove to join unto the thought before, but sequence rabbled out of reach like balls upon the floor. So when I meet a new patient, I have a split in my brain. One half of my brain is the oncologist half, which knows that this nice looking 50, 60 something young woman who has just finished a game of tennis, got a bruise, comes in, is diagnosed with acute myeloid leukemia. I look at this beautiful person and know what she's going to look like 6 weeks from now. And what her chances are, what we are going to do to her now. I know exactly all of that. And yet, on the other hand, my other half of the brain.
Dr. Azra, can I ask you a question?
No,
We're going to have a few minutes for
Yeah.
questions. I'll choose you first.
The other half of my brain is the half that sees the nobility of endurance, that actually is ready to undergo a new adventure with this patient, because who knows, this patient may be that one unicorn who's going to do beautifully and will come back 10 years from now with a grandchild to say hello to me. This happens to us also all the time. So one half of my brain is split into that realistic thing, the other half is always hopeful, always ready to learn about the new patient, to take them by the hand, to know something about their lives. And the disease I treat, it starts with a pre-leukemia which can go on for many years before it kills or develops into acute leukemia or kills from MDS itself. And seeing a patient week after week after week for years on end, that's the kind of, I'm very fortunate and very unique in that most of my patients will not die quickly. But I will get to know them with such granularity. We learn details about each other's families. We will really share so much of good times and bad times when they are admitted with fevers of unknown origin, neutropenic sepsis, and I'm taking them through all of that, but also taking them through a grandchild's graduation, as you said. How do I deal with this? What do I tell them? I mean, we are very realistic. We talk about everything, but both the patient and the oncologist will always stick to the positive parts of the conversation. I'll say there's a 20% chance that you respond. They will not think of the 80%, they'll think of the 20%. I too will think of that 20% all the time and keep thinking maybe it is that person who's going to defy all odds and is going to give me the most brilliant surprise. But the last thing I want to say is that Harper Lee, who wrote the book To Kill a Mockingbird, had a very beautiful saying. She said something to the effect that real courage is when you know before you start that you are already licked, but you are going to see it through.
The way I think about it, having spent a lot of time in the hospital and a lot of time lying on the sofa, is the prize doesn't go to the person who is dealt the best hand. It goes to the person who plays his hand best. You don't always get the great hand, but I'm up there, trying to beat the house.
Harvey said it in a different way. He said, I know that all this suffering I'm going through is not going to end in a joyous happening. But I will go through it because I'm a man and a man is responsible for himself.
We are going to stop having this conversation and start having this conversation and take questions from the audience. There's someone with a microphone somewhere?
And we'll go
There
first.
is someone with a microphone there, and we will go first to the gentleman in the blazer there. There's a microphone.
Please.
I'm just going to take you back to Toshiba. You just mentioned that the Toshiba has just announced that they from blood, this drop of blood, they can find out 13 different type of cancers. It is good. But did you find out from them that did they find any cure, any one of them? Or treatment for them? Or not yet, or still they are working on it?
Yes.
So if they are still working on it, we have to do the same thing.
Yes.
We haven't yet reached to that stage, but we will reach, inshallah, very soon, very quickly, and then we will, maybe as you just mentioned, you can find out the results much better earlier than them also.
Yeah.
Thank you.
Thank you, Madan Bhai. And I think that that's my cousin Zakir, whose daughter has probably already Googled Toshiba and found the 13th cancer blood test. But that's a very good point he's raising, that what do we do if we find the first cell? Do we have any fantastic treatments? I'm saying that, look, everything has to co-evolve. I'll give you one simple example. Let's say that we have developed bed sheets that you can go to sleep with and they will scan you overnight. For what? Scan you for any area in the body which is suddenly getting extra blood supply. Why is that important? Because cancer cells, as soon as cancer begins, it starts dividing faster than normal cells. So to grow, it needs more blood supply, it starts making new blood vessels. Area becomes hot. So let's say I go to bed tonight and the bed sheets pick a hot spot suddenly in my pancreas. It doesn't mean that I should wake up in the morning and have open abdominal surgery and a Whipple's procedure to eviscerate my abdomen and take out all the organs. Of course not. All it means is that now there is a suspicious thing which should be monitored carefully. Next thing, maybe I can do a blood test to see, is it showing up in the blood? Is there a marker showing up in my urine or saliva? And then keep following it. And once we find and confirm that number one, it is there and it is growing. Number two, that it is posing a risk to my life that is potentially lethal. It can kill. Once all those things are confirmed. And by the way, Grail, the company in America that is dedicated to early detection, have also announced recently that they can detect 12 cancers based on cell-free DNA. But based on a methylation signature, they can also tell the lethality of that cancer. Is it lethal or is it benign? Is it going to pose a risk to your life or not? So I'm saying that let's say now we have a hot spot, we have confirmation by 20 other tests, and that it is growing over the next 2 months when it is followed. We can then probably zap it with one laser beam rather than get 6 weeks of radiation therapy and months of chemotherapy. Or the same targeted therapies that are helping 20% patients for 5 months on an average, maybe will work much better. And that's the point I was making with chronic myeloid leukemia, that the very drug which is curative for chronic myeloid leukemia is completely useless if it becomes acute leukemia. The same drug. So the same drug that's curing the early part is useless for the advanced part. I'm saying the same drugs that are failing today, the targeted therapies, not the chemotherapy, they could work better. Laser therapy could work better. All kinds of things. These will co-evolve. But if we start imagining that, oh, if we find the first cell, what are we going to do about it? We don't have anything to do, so let's not find the first cell. No. That is not the answer.
Next question. Right over there.
Dr. Kasalbash. Oh.
Man, excuse me, I'm not a doctor, but I would still like that. You mentioned this prevention of your approach, but if you go further back, there are predictive aspects to this. And dealing with the predictive aspects, or you can call it preventative aspects, in a very early stage beyond it getting into the body, understanding causality of what brings it, and fixing that, you shift the funds, the $6 billion that you've been using for 50 years annually, you shift it to that, and you have a much better approach. In the sense that if you know too much acidic consumption is causing something, you change what is being produced in the food industry. I mean, it's a great business. You know, you make something that's not too good, you consume it, you find a cure, we put you through a process. Singapore has a way around this. Singapore says you get sick, you die, we continue. But if we go, one moment, if we go to predict, I bring this up, you see this in industry also, right? Where you have corrective actions for your equipment, let's say your body is the equipment. You have preventive actions in the maintenance place that prevent it from happening because you know it's going to happen. That's your early detection. But then you have predictive, which says because of this design, because of this consumption, this oil, this way of processing, this is going to occur. So you work on the predictive side.
I think
and you redesign what you're consuming, and then you have a good solution.
First of all, we're getting a little further away. Second of all, we actually understand many of those things, but we're having a hell of a time convincing the population to make the changes necessary.
Well, if you can convince the population to buy a television for $1,000, it's going to be $200 down the road, like you're talking about these medicines. We can convince them to consume something that prevents the cost.
25% of the population continues to consume cigarettes. Next. Right there.
I wanted to say one thing before Muzaffar asks the question, because the gentleman has raised some very important points, and we are in a vicious circle, causing a lot of damage ourselves and all kinds of things, and causing cancer. It's not that work is not being done in these areas for 50 years. In fact, in 1907, Dr. Childress said that it is not cancer that is incurable, it is the delay in treatment that makes it so. So early detection measures have been really tried since 1907 onwards. But I just was going to say, some things take you by such a shock. One of my cousins just called me last week to say that his grandchild at 2 months of age, 2 months of age, was diagnosed with a glioblastoma multiforme, filling the entire half hemisphere of the brain. How could this tumor have developed, filling half of her brain in 2 months of life? Obviously, it started in utero, in my opinion, that has gone missing. And this is the kind of thing that is so soul-shaking that no age is immune from cancer. We don't understand it, and it will take us another 1,000 years to understand all the intricacies of this type of cancer. It is so shocking.
I also, on the comment just made, I think that technology may get us there, and there's all kinds of work about changing foods and what's in them going on with that kind of, following that kind of hypothesis. We're going to change the way people, the whole population, are being exposed to agents which cause disease.
Yes, Muzaffar.
First of all, it's a fascinating discussion, and thank you very much, Dr. Raber and Dr. Raza. So I have read the book, so it's a beautiful book. It's a very elegant book, and my daughters, I'm glad they're not here, otherwise they would be rolling their eyes that I like to basically editorialize everything. But what I was going to say that I found 3 very touching things in this book. One, as someone who takes care of cancer patients myself, the empathy and the touching stories of your cancer patients, and including your husband and your friend's son or your daughter's friend. So those were beautifully written stories. The second part, of course, the science, both in terms of cancer research as well as early detection or prevention, touched and beautiful. And the third thing, of course, is Urdu poetry as well as Western canon, and how you weave all that with cancer patient stories and science of cancer. So this was brilliant. A couple of comments I would like you to make. Something like what Marty was saying about glass half full or glass half empty. So just this month, the American Cancer Society released the statistics that there was a highest drop in cancer death rate in the last reported year, which was 2016 to 2017. And if you look at the statistics from 1991 to now, there are approximately 2.9 million fewer cancer deaths than what was expected, almost 100,000 lives saved every year. And a lot of that, as you said, it's not just from prevention, from stopping smoking. Some of the things, at least that's the interpretation, maybe from some of the things that are done, like immunotherapy or some of the newer therapies that may be making some impact. So there is something to be said about...
Wait.
Let me just finish my question. I totally know that you have the answer.
I want to clarify
Yeah.
the mistake that you
But
made.
that's not the conclusion, but that's one of the interpretations. So that was one point. And the second thing is about taking care of cancer patients. Two things. One is that not everyone expects a cure. For many patients, as you and I and you alluded to, it's not about being cured. Sometimes it's going to that graduation or attending the wedding or those few 6 extra months so that that next ski trip. And then another thing is that life, about life, there was one of the NPR correspondent who used to basically talk about his illness every week. I think it was Monday morning with brain tumor. And he said that I talked to my oncologist and he was very frank and he said they would tell me you have less than 5% chance with this new drug. And he said I had no choice. I would take it because I want to live. So just your thoughts on this, 2 or 3 minutes.
That's going to be the last question. Go ahead with the answer.
Well, first, I want to thank Dr. Muzaffar Qazilbash, introduce him to all of you. He is one of the shining lights of oncology. I am very proud of knowing Dr. Qazilbash, part of the transplant team at MD Anderson, someone I have known and admired for many, many years. He's absolutely one of the most brilliant people. You can't walk 5 steps at MD Anderson before somebody stops me and tells me, do you know Muzaffar? He's great. So he is really great and we love you. And thank you for your reading the book. Thank you for your kind comments, Muzaffar. So for everybody, I'd like to make a couple of things clear about what Muzaffar said. Number one, there has been a 70% decline in deaths from heart disease in the last 30 years in America. 70%. Compare that to 1% per year for cancer. 70% to 1%. Why the difference? Cardiologists became smarter. They knew prevention is better than cure. Not only do they fix the coronaries way in advance, they prevent atherosclerosis by giving statins and trying to reduce your cholesterol. So they work backwards all the way and they have been smart and they got to this. We proudly proclaim that mortality for the first time went down by 2% instead of 1% this year. Really, that is cause, first of all, for giving ourselves gold medals and proclaiming from the rooftops. A lot of people are questioning that American Cancer Society should not even have released this information because it is so misleading. Everyone is so starved for good news in cancer that newspapers immediately pick it up and start announcing this, that there is a dramatic drop in cancer, deaths from cancer. When you read the fine print, it's gone from 1% to 2% just for that 1 year period. A lot of people started saying, oh, the immune therapies are working. In fact, the president took credit that, oh, my policies made the difference. He wasn't even president when this happened. Secondly, most importantly, immune therapies were not used in these patients. Not at all. So nothing has to do with immune therapies. Peter Bach from Sloan Kettering pointed this out, and Vinay Prasad from Oregon. Both of them pointed this out. And I actually was expecting this question from Marty, so I had brought it on my cell phone, the questioning of 5 reasons to suspect and to question and to condemn this kind of misleading the public. Making the public believe that we are making big inroads in cancer research and treatment. Look, we have doubled the rate. Doubled for 1 year, for one insignificant thing, it will probably go down to 1% again. Because these blips happen. And even they admit that most of that drop is now from the anti-smoking campaign that's showing them and from early detection of cancer. It has nothing to do with immune therapy because those were not even used by then. So I wanted to clarify that immediately. Do not leave this room thinking there is a grand sudden success, a dramatic fall in cancer deaths in the country. It is not so. And second, I think that you wanted to add something?
I think what you say is exactly true, but I also think the successes of immune therapy are greater than you give them credit for.
Who am I to take away credit or give it? I only quote statistics. The statistics are that only 15% targeted therapies can be matched.
Yes.
And of those 15%, not everyone is going to respond. 30% of those 15% will respond, and the maximum benefit is an average of 5 months. But there'll always be a unicorn who will go and respond.
I don't know. We agree completely.
No, I am quoting statistics. I don't want to give sweeping statements like this. I have backed everything up with like pages and pages of references. This is full of statistics.
Then you have to look at the statistics for melanoma and the
Yes,
checkpoint inhibitors.
why do I
You
not?
have to
I
look-
admit it.
you
There's
have
a
to
very
look-
small, yes, for
Yes.
rare cancers, there's been a big
You have to look at the emerging statistics for lung cancer.
And melanoma is
checkpoint.
10 months. Melanoma is 10 months with
Melanoma is 30% of the patients 5 years later on the tail end of the
that I agree
curve,
with
probably
completely. It's a
cured.
very small, rare kind of cancer
Lung
that
cancer
is.
is not a rare cancer, and its curve is about 30%, not 50%, coming up in 3 years. The use
I have
of
all the
the
statistics
use,
in
the use
here.
of
You're not giving me any new information.
No, I understand that, but when you speak about it, you dismiss it,
No,
and
I'm
those
not
are
dismissing
should not
anything.
be
Look,
simply
I have
dismissed.
got it on my cell phone. If you hand me, Stat News yesterday has this big article, 5 reasons to question and condemn and suspect this kind of thing. I'm not saying it. Peter Bach from Sloan Kettering and Vinay Prasad from Portland, Oregon have said this.
Azra,
So it's not like, no, I don't want to leave people with this image that Marty is telling the truth and I'm making some stories of it. Absolutely no.
Azra, as they say, the little hand is already past 6, and we're 10 minutes over already. There is a book signing coming up.
I think there's one last question.
One last question.
A quick comment first is that I think Azra is looking at that big picture, and I know oncologists and all are kind of like one cancer, out, improve survival. That's true, but the big picture is still the same, apart from a couple of cancers where we made major headway. Another question I have is, are there statistics that, I'm a rheumatologist, so I see a lot of checkpoint inhibitors, side effects, and all that stuff too. And then of course, these are still less than some of the chemotherapy side effects that we see. So the question is there any data to look at, the mortality, what percentage of people are actually, what mortality is due to these complications of the treatment or that versus to the cancer itself? And that's one thing. What about morbidity of like living with that cancer versus, it's a kind of a two-way, just like you're saying in cleavage. Like, do we have any data on that? And like you said, looking at a patient's family 15 years down the line. I had my father 15 years ago passed away with cancer, and I was a 25-year-old optimistic, wanted to do everything. If I look back now and look at the survival benefit which he got or didn't get, to me it's a different picture looking at the big picture versus everything we were told at that time of, it's going to improve this, it's going to improve that, it's going to better. And so I think those kind of things are important to have as well. I don't know if there's data about that already or not.
Yeah, there's a lot of data about it, and on the whole, for a definite percentage of patients, there is improvement in survival, but they pay the cost for it by having a lot of physical side effects as well as financial toxicity. Right now, 44% women in this country with stage 4 cancers are being hounded by collection agencies. 42% people who are diagnosed with cancer today, 42% are completely financially ruined by 2+ years of their diagnosis. Completely financially ruined, losing every penny of their life savings. So financial, physical, spiritual, emotional, all kinds of toxicities, and this is being looked at in great detail. I'd like to end by inviting Dr. Uzma Iqbal, another wonderful oncologist in the community, to
So
give
I'm
us
just gonna, thank you, it was wonderful. I think the authentic exchange was very refreshing. I really, really enjoyed it. So I just want to say that as a cancer doctor who treats cancer patients community, it's a constant challenge of hope and honesty. You know, as a doctor, every day you just walk in with hope, and sometimes you just come out with the honest truth. My cousin, who's a researcher, basic research, scientific research, calls me occasionally with amazing excitement and says, Uzma, we are onto this. And I say, when can my patient get it? And he says it has to be about 10 years. So the bench to bedside pipeline is about.
It's down to 10 years.
It's down to 10 years.
And then from the bedside to trench. So from bench to trench, it's 20 years.
So I want to actually end on empathy. You mentioned empathy. The book mentions empathy. The empathy is not only important for the patient. I think it's very important to regenerate the emotional reserves of the treating physician also.
Yeah, we never got a chance to really address that.
Because without that, there will be a whole lot of hollow people moving around. So I wanted to actually end on that empathy note and say kudos to everybody, who is treating it and the people who are suffering from it, and appreciate everybody's help.
Azra, you want to be around for a few minutes? If people want to ask you specific things, I'm going to be around for a few minutes. But I think that we're way over time for the talk.
I think we both need a drink now.
And I really appreciate it.